I'm so excited to share this week's episode. So I interviewed Andrea Dalzell, who is a nurse, disability advocate. Turns out she is also an NP school, which I'm so excited about. And what we talked about is a really wonderful conversation about how to best support our patients with disabilities in primary care, how to have conversations with patients, things to say, things not to say, resources that are available, and why this is so crucial for us to talk about in primary care. And one snippet, spoiler alert, not really, but the true path to systemic change starts with individuals and interpersonal relationships. So without further ado, though, you'll hear more about it in the interview, but here's my interview with Andrea Dalzell. Well, hey there, it's Liz Rohr from Real World NP, and you are watching the Real World NP YouTube channel. We make weekly episodes to help save you time, frustration, and help you take the best care of your patients. Awesome. Thank you so much for being here. Can you introduce yourself to the Real World NP community?
Yes, my name is Andrea Dalzell, and I'm affectionately known as the seated nurse. I am the first registered nurse who uses a wheelchair to get through nursing school in the state of New York. That's been 4 years now. It's crazy how time is flying, but the word is out, and more people with disabilities are coming into the profession day and day. So.
Awesome. Beautiful. Well, I'm so happy you're here. Yeah, there are so many places we can go, but I think a place to start, just to kind of get into the conversation, where do we even start when it comes to talking about disabilities in healthcare, especially in the primary care setting, as most of the people that we serve with Real World NP are in primary care, but just generally speaking, what are your thoughts about that?
Where do we start? That is the best question ever. You know what? It's kind of hard to always pinpoint where to start, but I think what we need to recognize first is language.
Mm.
We, as a profession, use language that can literally make or break a person just by how we introduce something, right? A
Yeah.
diagnosis,
Yeah.
um, livelihood, changes that will happen. When
Mm.
you use very restricting language, like bound, wheelchair bound, it's
Mm.
like, wait
Mm.
a minute. Am I stuck to something for the rest of my life? Like what
Yeah.
does that language really mean? We got to get to the nitty-gritty of it and how we portray something to people, because healthcare and science, we have this bad habit of just using the terminology without actually understanding what that means in the livelihood of it.
Mm-hmm.
So when I say like wheelchair bound, we notate wheelchair bound. Like I'm actually not bound to my wheelchair. My wheelchair doesn't sit in one place. It's not locked in. It's not, it may have a seatbelt. It may have things to help me stay in the chair, but I'm not bound to it, right?
Mm-hmm.
When we say someone is bound to something, bed bound, home bound, we're emphasizing that this human is not living in a way that we would see ourselves normally living.
Mm-hmm.
Right. And sometimes we got to change that narrative, because when you're diagnosing someone and saying, well, this is the possibility that you may happen, you start to scare them away from what disability actually looks like. Disability is not a bad thing, it's human nature.
Mm-hmm.
Everyone in human nature is going to experience some form of disability at some point. So when we sugarcoat it and act like disability is this horrible thing, we shy away from it. We think
Mm-hmm.
about it as a death sentence. It all comes down to wording, and the wording really comes from healthcare first.
Mm-hmm.
Healthcare is the one that literally kind of notates, documents, and sends out to the rest of the world. We send out the why you're medically absent from work. We send out the reason why you need medical accommodation. And
Yeah.
that wording then plays into how other corporations and facilities and
Oh.
everyone else kind of utilizes the language.
Oh my goodness. Oh my gosh. I just love everything you said. I think especially for newer clinicians, whether you're a nurse, whether you're a nurse practitioner, physician associate, I think that it can be so overwhelming to try to do your learn all the things you need to learn in school and do the medical stuff. And so it's hard to not get sucked into wait, what am I doing for a diagnosis? What am I doing for a plan of care? And to think about things like what language we use with people And also, like, it makes such an impact. And like, that's such a point you made about the fact that, like, it's not just the way we talk to patients, we talk to people and the relationships that we have, and like how language really does influence our culture and the way that things change, and the supports we have. Like, it starts at this interpersonal level, or like internal level, interpersonal, institutions, ideologies, right? And that like really all wraps in together. But like, I love the point you made about the fact that, like, initial diagnoses come from healthcare providers, and like that
Yeah.
language is just takes off.
Yeah.
So what are some examples, of language? You already gave like wheelchair bound, bed bound. Like, what are some of the other language pieces that you see and that are like kind of like cringeworthy, or just like substitutions? Like, what is, because it's about the language, but like the thing that underlies language, at least this is how I feel, is that it's the perspective. It really changes your perspective. So what are some of the examples that you would say for people to think about or watch out for?
Well, yeah, we are not going to sugarcoat human need,
Yeah.
right? Nothing is special about human need. It's human need.
Mm,
Whatever that person needs to survive within their circumstance, situation, so forth.
yeah.
So we're not special needs,
Mm,
right? We're not going to say, we do not say the R word, and I will not say it on this
yeah.
podcast. If you're using it, whether you're saying mental R, it's
Yeah.
not correct. It
Yeah.
should be removed from your vocabulary. Um, Even someone who is disabled, special person with special needs, none of that. We're not going to sugarcoat disability. Person first language is giving the person, like this woman with a disability, or this person with a disability, you're acknowledging that they're a person before they have the
Yeah.
disability, is what we're really notating. And it kind of conforms with gender, and just asking how a person wants to be described
Yeah.
when you get
Yeah.
the introduction happens,
Yeah.
whether you're getting that intake form from the front desk and you're ensuring that that intake form says, first name, last name, preference name,
Mm, mm,
preference sex,
mm,
preference, how would you like to be addressed? It's
mm.
how you kind of approach the situation, whether you make the little change by seeing that it's not on your intake forms, and then you're saying we need this on the intake form, so that
Yeah.
you're understanding how you're addressing your patients, and then understanding that we're not going to sugarcoat whatever it is that is happening. Disability can suck. We know that, and we can say that.
Mm,
So
mhm.
say that. We don't need to add anything to it. Like, special need, why?
Yeah.
Why? You're
Yeah.
human. This
Yeah.
is your human need in this moment, and we have to make sure that you can get it. I'm not going to say that that's something special, because it's not. It's what you need. Somebody else may need the same thing, but when we label things special, bounded, we kind of seclude them from being a
Yeah.
part of everyday life.
Yeah.
And we wouldn't want that for ourselves. So
Yeah.
just kind of remember that part.
Absolutely.
Like,
Yeah.
at the end of the day, yes, we're talking about language and how we introduce it and how we want people to feel secure in how they interpret what we're saying.
Yeah.
But we also have to understand what we're actually saying has that impact. And would we want that for
Mm,
ourselves? Would we want to hear the words bounded, or never will, or you're special now, or mental R, or, you
mm,
know,
mm,
anything that's cringeworthy? Like,
mhm.
we wouldn't want to hear it for ourselves if we were in that situation. So it's
Yeah.
kind of best to not label it, but call it what it is.
Yeah. Yeah.
And you can always put a respect effort into that. This is
Yeah.
in no way meant to, reflect any disregard to you, but this is what we're seeing. This is how we're going about it.
Mm,
How are you feeling comfortable?
mhm.
Because at the
Yeah.
end of the day, if the patient's not comfortable, then you're not going to get anywhere in your conversation or your language, because that patient's going to be stuck on one thing that
Yeah.
was said.
Yeah, absolutely. And that brings us to we had some questions from the real world NP community. And one of the questions was, I think that and I feel like I hear this, is like, I feel like people, they want to give really excellent care to all of their patients. They want to be respectful when it comes to conversations about disability. And so but they were feeling like uncomfortable. And so it's like, their question was like, what would you recommend in terms of like respectfully discussing disabilities with a patient, especially like in the primary care setting? It doesn't have to be, but those are our primary kind of audience members, but how would you suggest to talk about in a respectful way bringing up disability, especially if somebody hasn't brought it up to that person in the first place, that provider?
Well, I think at the beginning of it all is where your introduction starts.
Yeah.
If it's a new patient coming in, it's first time that you are dealing with this patient, you ask the whole history just like if
Yeah.
anyone else would. And then
Yeah.
my diagnosis is transverse myelitis.
Mm-hmm.
It's a neurological inflammation of the spinal cord. It affected me. I'm an incomplete paraplegic. When I go and I see a new primary care doctor and I write that diagnosis down, my hope
Yeah.
is that when I go into the room,
Yeah.
my doctor doesn't have to know what my like what that particular disease process is,
Mm.
but I hope that when I'm going into that room and I'm meeting with that physician, that NP for the first time, uh, that they're asking me, how does it affect my life?
That's a really
Not
good
what they
question.
know,
Or
not what
assume.
they read or
Yeah.
assume.
Mm-hmm.
They're going to ask me, how does transverse myelitis affect your day-to-day activity?
Mm-hmm.
I want to hear what you're telling me
Mm-hmm.
because as a nurse, when I'm doing my assessments and when I'm going through, I'm looking at the whole picture, right? Because nursing, we're
Yeah.
holistic, we're taking into account everything that's happening. So now I've never seen you before. I'm doing an intake on you, and I want to know, how does this process affect you? Just like if
Mm.
someone has diabetes coming into the room and you know
Yeah.
that their sugar is like in the 800s and you're asking them, well, what did you eat for breakfast?
Yeah,
What did
totally.
you take your insulin? Right? The same question that I'm going
Yeah.
to ask someone that's presenting to
Yeah.
me with some type of physical disability. Can you tell me how your day-to-day life is affected? That
Yeah.
way I can now start to have a baseline,
Yep.
of what happens throughout your day, what happens throughout your weekly, monthly, yearly, so that at the
Mm-hmm.
very beginning, primary care, that's what we're at, is going
Mm-hmm.
to say, well, no, something is off. She's not, her heart rate's now elevated, her BP
Mm-hmm.
hasn't been down. There's something that we need to adjust, especially for wheelchair users or persons like that have quadriplegic or who are tetraplegic, who go through traumatic brain injury or
Mm-hmm.
CVAs or paraplegia. All of these are all encompassing. So yes, I'm talking from the person with using a wheelchair, but I'm really encompassing all disability here because
Yeah.
again, disability can affect anyone, whether you're talking about the person with diabetes who had an amputation,
Mm-hmm.
whether you're talking about the person who had a CVA,
Yeah.
whether you're talking about the mom who had a cesarean who had maybe other complications, who are now going back into the work field, who are dealing with scar issues or other things happening. This is all encompassing of disability that we don't think of. We think of what we see visually. What about those patients that are even who have invisible disabilities,
Yes. 100%.
right?
Yeah.
Where we don't even know what their day-to-day affects are because we don't understand what that disease process is doing for them day in, day out.
Absolutely.
But
Absolutely.
we know what the diagnosis is, so we assume that they're automatically in that. This is what's going to happen. This
Mm-hmm.
is what you're doing. But livelihood and diagnoses are not the same.
Yeah.
At the very basics of primary care, we need to know what those diagnoses are doing to that person day in and day out.
Absolutely. Absolutely. It kind of reminds me of, so I think some experiences, it seems like there's a bit of a process, right? Like for some, I've had some people where they have like some sort of neurological condition, for example, and they get progressively like less function over time. And they're really kind of grappling with disability, of like calling it disability, like using that language. Do you have any thoughts or guidance like around that, or just, yeah, just any sort of reflection about, I don't know if you see that a lot or if you had any recommendations about that. I guess I'm just thinking about a
Well,
particular patient having a hard time with calling it disability and receiving assistive
yeah,
support.
we are human, and our human design is to believe that we are invincible. Nothing will happen to us. And when that hits the fan, when you sit in a doctor's office or an NP's office and they give you some diagnosis that you were just not expecting to
Yeah.
get. and your world turns upside down. And here is where we
Mm-hmm.
backtrack to language.
Mm-hmm.
How are we presenting what disability looks like? And then
Mm-hmm.
with our own language and our own interpretation going
Yeah.
back out into the world, because like I said, this is the circle that we're in. Healthcare drives the narrative.
Mm-hmm.
NPs, primary care particularly drive the narrative to the outside world.
Mm-hmm.
What other corporations, facilities, institutions are reading on that paper, what you can and cannot do based on disability,
Yeah.
right? Versus what that
Yeah.
person can do in their livelihood.
Yeah.
Then that turns into representation. Are we seeing people with disabilities in media? Are we seeing
Mm-hmm.
that in our everyday lives? Or are we still continuing the narrative that a person is wheelchair bound, so they're going to stay home? That this person has this new diagnosis, and because it's going to get progressive, they should already start to rest and not be a part of their livelihood instead of being pushed to see what they can continue to do for how long they can continue to do it with the right supports in place.
Mm-hmm.
So that's one end of that. That person grappling is because of the fact that they don't know what to expect. They don't know what to look for. They don't
Yeah.
know what to even ask for.
Yeah.
So saying disability, it's like, wait a minute, I'm not disabled. I can still do it.
Right. Right. That's
But
such a
at the
good
same
point.
time, disabled doesn't mean that you can't do something. It's because
Yeah.
our language is determining that you cannot do something, not that you cannot.
That's so
And
true. Yeah.
when we're talking to people, we have to remember that if we're presenting something that may be disabling at some point,
Yeah.
we're saying to them, disabled is not a bad thing. We're getting you the supports that you need to continue your livelihood,
Yeah. Yeah.
right? Disabled doesn't mean you
Totally.
cannot.
Yeah.
Disabled means that we're going to get you the supports to continue,
Yeah.
right?
Yeah.
But comes to language, it comes to how we
Absolutely.
present it. If we present it as a negative, it's
Mhm.
going to continue to be a negative versus if
Yes.
we present it as a human need and we're meeting your need,
Mm-hmm.
great. We're here for you. And now you feel supported. And now you can open up to us and tell us at your next appointment that this is working, this isn't working. And now we can actually hear
Mm.
and do better.
Yeah. Oh my gosh. I'm like really emotional actually, just like hearing you talk about that. Cause like, I don't know what it is, but I think like, so I did an interview recently with somebody, a diabetes nurse practitioner, and she was talking, and I love the way she described this. I think that there's like a couple of things that is bringing up for me. Like one is that there's a lot of, it's not only the language we use, but like what does that language mean to that person? Like I think that's really the thing that's coming through here is like it's really just about like assumptions. What is your knowledge base? And like what is your knowledge base as like the nurse, as the nurse practitioner, as the provider, and like what assumptions are you making about that person, or what assumptions is that person making about what that means, what you told them, right? There's seems like there might be a breakdown there. But the other thing it reminds me of is in that conversation we were talking about starting insulin for patients who have diabetes is can I think a lot of people, my anecdotal experience is that they tend to get really discouraged and feel like they did something wrong or they failed, or like it's just this discouraging, like, oh, like not good feeling. And like I just love the language that she used was about like when she explains it to people, it's like, okay, well, there's a hammer for hammering needs and then there's screwdrivers for screwdriver needs, right? Like you just use the tool that you need for your
Right.
needs, right? Like it's matter of fact, it's plain, it's like okay. Like I think it's just like what you're saying is so highlighting. We just have this like norm, like this cultural norm, like in healthcare in the US, like talking about disability as being like this negative thing, this other thing. But like really, it's just everybody has needs, and what are the needs that they have, and how do we support them as like a whole human? So I really appreciate you saying that, and it's so great.
Thank you.
Well, I have a question here. So another question this kind of ties into is what a question from the real world community is what barriers do you think could be removed to make primary care more accessible? One barrier, multiple barriers, like any barriers that you can point to specifically in primary care that could be removed or
Well,
amended.
yeah, as an assistant nurse manager in a primary care facility right now, I can tell you, and I'm in a medical desert, so that goes to tell you as well,
Mm,
what my resources may be. I'm limited, but I have people who are coming into my facility with CVAs and strokes and TBIs
Mm,
and paralysis and everything under the sun. And I go into
mm,
my clinic, and my clinic doesn't even have waiting rooms that are significant space to be able to hold a wheelchair or walker or mobility devices,
mm.
right? Your waiting rooms are so packed with chairs that where does a mobility device live?
Yeah.
Think about that part. That's
Yeah.
just is your facility even like
Yeah.
set up to withhold mobility
Absolutely.
devices? Or is it really just set up for
Absolutely.
healthy people to walk in, they be seen?
Mm-hmm.
Right? What about your rooms? I think about just the
Oh my
basics, just the
gosh, the
structure of a
rooms.
room. Okay.
It's
We don't think
wild.
about these things.
Mm-mm.
I worked in a hospital system where when I was going on shift, the person that was coming off shift, I would pull them and ask them to help me reset my room because I'm in a wheelchair and I need to make sure that I can get around the room easily.
Totally.
I'm in primary care now, and I go into one of my exam rooms, and I'm like playing Tetris between the bed, the chairs, the
Uh,
stirrups, like everything is everywhere. The scale, the garbage can. It's like you got to get things
mm-hmm.
out the room just to be able
Yeah.
to move around
Yeah.
as
Yeah.
a primary care provider. Now, if I have
Yeah.
another patient with a mobility device who comes in with an aid, who maybe can't get up on the bed because the bed doesn't go up and down, who
Yeah.
can't get on the scale because the scale is only for someone who can step up. These are basics,
I
basic
was gonna
needs
say it
to
just keeps
have.
going.
Right? It's basic things when you get into, how about getting into the office? Are you near transportation? Do you
Mm,
offer parking? Is your parking lot with accessible spots for wheelchairs or walkers or canes
yeah.
or service animals to be able to get out? When they come into your waiting room, is there height adjusted seats so
Yeah.
that someone who may not be able to bend too low can still sit down?
Yeah.
These are basic things that I'm thinking about. But
Yeah.
that's just the basic access to primary care, not even specialty service. So for me to find a primary care provider, that's not OBGYN, that's not even hematology, that's not urology. It's just my doctor who I need to see,
Regular.
make sure
Yeah.
that my blood work looks good. And if I need to see a specialist, I can go, right?
Yeah.
Like the
Yeah.
basics the basics for prescriptions. Like, why do our patients not come into the office to see us before they end up in the ER? Because
Yeah.
the ER is accessible. The
Oh,
ER is accessible,
it's so true. It's so
right?
true.
So those are things you got to think about. Like, why are we not getting patients? How do we get more patients? How do we even ensure that we are free for them to come in? It's just the barriers. Are your
Mhm.
websites accessible? Can someone who is visually impaired or hearing impaired
Yeah.
access your stuff?
Mm-hmm.
We don't think about these things because it's not incorporated into our learning. The
Mm-hmm.
language isn't a part of our learning. We're not,
Yeah.
when we talk about disability, we're thinking about, okay, they may not be able to walk, we may not be able to talk, they may have aphasia, they may, all of these things, but we're not thinking about the livelihood. Now, how do they get into the office? Is there transportation? Can they come can I get them on a scale? Can I weigh them? A lot of our calculations are based off of weight.
Yeah.
And I can tell you that the amount of patients that don't get weighed in just primary care
I was
is
gonna
significant.
say, I mean, I think that's I see this all the time. And it's just like, when have we gotten to wait on this person? They have heart failure. This is really important. Like, it's important regardless, but it's like, wow, that's really horrible. Yeah.
And that's just basic, right? Or even just to get onto an exam table.
Yeah.
Does
Yeah.
the exam table come down? Do you at least have one
Yeah.
exam
One
table that
option.
can come down, up and down, so that if someone can't get up, can we still do a physical assessment on them and get something good? Again, like I said, I'm paraplegic, I'm an incomplete, I cannot stand. So when I'm inspecting doctor's offices or consulting, I'm often looking for what their assessment intake would be for like someone like me coming into the room.
Yeah.
So
Yeah.
if I get up on that table, can I turn left and right? Can you do a skin check, right? Because
Mhm.
that's what's happening in primary care. You should be doing a skin check on someone who has, neuropathy or paralysis, because you should be making sure
Yeah.
that the skin integrity is good for the long term.
Yeah.
Doesn't happen either, especially if there's a weight discrepancy. Now I've seen you 6 months, if you gained some weight, you're sitting in a chair. I may need to order a new chair and I can't get you on a table and I don't have a weight,
Oh, that's so painful. It's so
right?
painful because it's like, no, it's subpar care. That's
But
that's not okay.
but how can it be subpar care if the basics of your information that you learn doesn't include it?
I know. I know.
right? The basics of what we learn, especially in like NP school. Like I'm in NP school now, so I
Yay!
can say that.
Oh, I'm so excited. I didn't know that. Oh my God, amazing.
That's a special release for this podcast.
Excellent.
Right? Finished my master's in nursing education and now I'm in NP school. So, I got these textbooks and I'm like looking through it and I'm like trying to like see what they're saying and, understanding
Mhm.
just the basics and absorbing it. And I'm like, wait a minute, we don't even talk about disability at this level either. Like it's not
Mhm.
integrated into what a diagnosis would be. It's not integrated
Oh,
into what my
absolutely.
assessments would be.
Yeah.
And I'm like, so do I need to complete like a whole new assessment? Like, what would be a great assessment for these
Yeah.
particular categories?
Yeah.
And a
Yeah.
lot of people say, well, that's in specialty. And I'm like, do you know what the wait list for specialty is right now in
Mm.
America? Do we know what insurances are putting up against seeing specialists in general?
Mhm.
This is where primary care really can integrate into community health and
Yeah.
say we have thought about these things and we're implementing
Yeah.
them and really pushing the American boards to say, you know, specialty care starts with primary care.
Yeah.
And, and we have to be able to do these assessments and we have
Yeah.
to be able to have basic access to
Yeah.
be able to do these assessments.
Definitely. Definitely. Oh my gosh. That's so, yeah. I mean, I guess the way that I'm thinking about it too is like I have this systematic approach. I shared with you I have ADHD, and I
Mhm.
think that that helps me like do the same thing in the same way every single time. And so when I think about assessing with disability, I'm thinking about how do I approach like eye pain? Like how do I approach a cough? Like what is that differential diagnosis, but also like what are the assessment pieces? And like
Right.
that is like a very clear opportunity in there of like, okay, you have somebody who uses this assistive device. What is your checklist of things that you're going to assess for that person? What questions do you want to ask? Like, what is the metric that you're going to measure? And it's like, as we're talking about, it's like, of course this should be in the curriculum, right? Like, this is so easy, just do it.
Right. And,
Yeah.
and again, it's not just for someone who's a paraplegic. Like we can also
Yeah.
attribute someone who may have a CVA who's now coming in
Yeah.
who may have had tetraplegia or quadriplegia or
Yeah.
hemiplegia, and maybe their hand function is lessened and they're constantly in clenched fist. Maybe we should be saying they should be using a stress ball or getting fitted for a brace, and while they're waiting for a brace, they should be doing this, right? Like these are all the
Yeah.
things that we should be thinking about just in
Mm-hmm.
primary assessment.
Mm-hmm. Definitely. Definitely.
Before you leave us, let's make sure that we have this in place.
Yeah.
Like,
Totally, totally. And that makes me think of we had a couple of questions, and we had a couple. You and I had a couple of thoughts about this. We had a specific question about workplace accommodations. Like this person has a neurological condition that is progressive and has concerns about just navigating that for themselves in terms of what that looks like. Maybe starting with that, and then we can talk more about like what are some things people don't know about workplace accessibility and like resources. So maybe the first question to start is about like what are workplace accommodations? Like what does that mean? What does that usually look like?
so workplace accommodations literally is to make sure that you can do the job with the at the capability that you're able to, how you show up. It's
Yeah,
not giving someone a leg up.
yeah,
It's not, making someone's job easier.
yeah,
That's not what an accommodation is. An accommodation is so that they can actually do the job the
yeah,
way that they can and
yeah,
in the capacity that's safe.
yeah,
And a lot of we use this negative term around accommodations or workplace accommodations. Like, what does that mean? Like, do I need to get anyone can get it at
yeah,
any point in time? And I love to reference a woman who has had a baby who now comes back to work who may be on a pumping schedule,
yeah.
right?
Oh,
And she needs to get those workplace accommodations so that she can take that half an hour at a pump every 2 to 3 hours,
yeah,
right? Is that really an accommodation? I'm a woman. I'm going to say, no, that's not an accommodation. That is a very necessary need that needs to happen. But for the patriarchy, yes, that's an accommodation. And that doesn't give that person a leg up in their job. That's meeting their need so
yeah,
that they can continue to do their job.
yeah,
Right. And I
yeah.
think that's what we have to meet first. We're meeting human need.
Mm-hmm.
Healthcare workers are not synonymous with being healthy.
Mm-hmm.
Not because we're healthcare workers means that we have to be 100% healthy.
Yeah,
That narrative is false. And when we continue to perpetuate that narrative, we put a stress onto us that is unobtainable. and a sense of perfection that
Yeah.
will never be achieved, because
Mhm.
we're human beings at the end of the day, and we have human need. Like
Mhm.
our nurses that are going through, I don't mud right now in Fort Lee and
Mhm.
in Florida. We're right after Hurricane Ian,
Yeah.
and these
Yeah.
nurses and these healthcare professionals have shown up and lost everything and continue to take care of other patients while their human need is at the bottom of their priority list. But
Yeah.
they're working through trauma. And
Yeah.
if we were really to consider that as a profession, we would say that their accommodations would that they would take a month off after all of this, right?
Yeah.
That would
It
be a
is.
decent accommodation to
Yeah.
say after you work through 13, 14, 15 days post a hurricane where you've lost everything, possibly family, that you take some time for you.
Yeah.
And accommodation is making sure that your needs are met.
Yeah.
But, we're again in a capitalist society. And, what I say is the pipe dream. But that doesn't mean that we can't advocate for it. And it doesn't mean that we can't advocate for our needs to be met
Yeah.
at our workplaces, whether we have a disability or we don't.
Yeah.
Because again, and I love to say this, disability does not discriminate. It
Yeah.
is one of the class systems that anyone and everyone can join at any given point in time. It does not discriminate,
Yeah.
right? We are the
Yeah.
fastest and largest growing majority in the world.
Yeah.
Okay, we have 1.8 billion people who self-identifies with a disability, let alone those that do not identify,
Yeah.
right? So
Yeah.
if you have the opportunity to join at any given point in time, then you need to also remember that someone who is meeting you in the place that you're at is deserving of any accommodation
Yeah.
to allow them to be human and
Yeah.
live. So that doesn't matter whether we're in healthcare or not.
Yeah. Yeah, and it's like such big stuff because this is such like a cultural movement conversation. Like it's really ooh, it's just it's so much. Like it's really like it's all rooted in that, right? Because I think that people I think the question if I'm reading the subtext there is that there is a lot of fear. There's a lot of uncertainty and a lot of fear of like how do I navigate this? I'm going to get pushback. Like you were saying of like, it's a leg up, like there's this negative connotation with it. So it's really it is really tough. One of the things that you had brought up before is talking about I believe it was you were talking about ADA resources, or you were talking about like what is it that people don't know about whether it's workplace accommodations or accessibility? Like what is it that people don't know that you like wish that they knew?
Oh, that your job is not where you stop. Like,
Yeah.
if your job says no, go up. Go up. Listen, and as this started for me since nursing school. I got into nursing school based on merit. And
Mm-hmm.
then when I was in nursing school, I was told, like orientation level, told that I wouldn't be able to be a nurse because of my wheelchair and, going into the hospital system, infection control, and not being able to do CPR and all of these assumptions. And I had to prove a point that I could do it, and please don't put this assumption on me. And I went through school without an accommodation. And that was harder on me to not ask because I didn't want the notion that I couldn't do something.
Yeah.
And you weren't going to say, well, she could do it because of an accommodation,
Mm-hmm.
right? But then I had to shift my own narrative. Wait a minute. Accommodation isn't a bad thing. If
Yeah.
I need 10 minutes extra time, then I need 10 minutes extra time. If I get 20 minutes to go use the bathroom every 2 hours, then I am given my 20 minutes to go use the bathroom because everyone else can go to the bathroom and not have to worry about it. Where I may have to go find an accessible stall on some next level floor, right? Remember that your human need is the most basic thing that you have to meet in order to show up as your true self at any job.
Mm-hmm.
So you asking for an accommodation is not a bad thing.
Mm-hmm. Mm-hmm.
The job force that may say no to you because they don't want to pay for your accommodation or implement your accommodation, or saying that it is too burdensome, go above them, file a report, put in
Yeah.
those reports with the ADA, put in those reports with JACO, put in those reports with a commissioner of your state, put in those reports with the EEOC, which is the Equal Opportunity Employment commissions. Like, do not
Mm-hmm.
allow for corporations, facilities, or institutions to tell you that they cannot meet your human need
Mm-hmm.
for you to be able to work.
Yeah.
If you still can work and you have the ability to do so, don't let someone say that you can't.
Yeah, absolutely. Absolutely. So I like to ask people who are a specialist in some way, when I do these interviews, from your paradigm of your specialty, what is like a pet peeve that you have, or what is something that you wish primary care providers knew?
Ooh, everything. I can't
Go
give
for
you
it.
textbook,
This is soapbox
right?
time.
I can't take textbook back, but like honestly, my pet peeve is just like when you're filling out these forms and like I understand that some people are gonna come in and you get inundated with forms and that you automatically are assuming they can't do something where you're gonna put down like unable
Mm,
to reach, unable to stand,
yeah.
because that's what these forms are asking. How long could they stand for? How can they
Yes.
reach? Right? Can
Yes.
you not say that I cannot stand? Like I sit down perfectly fine. Standing is not the option here for me, right? I can sit for 12 hours, but if you say I can't stand, my job automatically thinks I can't do the job, right? Like
Interesting.
this is like I have to get paperwork
Mm,
done like to a T because it has to go based
mm,
on what my ability is, not based on what the wording is, right? And the
mm,
wording's going to say, the wording's ableist. The paperwork is ableist. Paperwork is coming at you as, can you be this perfect human? Are you 100%
mm,
quote unquote normal? Right? No one's
mm.
normal. So can you stop
Yeah.
trying to fill out
Yeah.
paperwork as though someone is fitting the box of normalcy that doesn't exist?
Yes,
Asking if
exactly.
they can stand, like, what is the job for? How long are they standing? Should they be standing for 6 hours or 12 hours anyway? Your medical opinion, do you think that that's okay? No, it's not okay. There
Right. The
should be
norms
a
are the messed up thing. Like the cultural norms of what's expected is the thing that's messed up.
is
Yeah.
really messed up. But then
Mm.
we the pet peeve is that we enforce those cultural norms by how we continue to address them just by paperwork. And I understand that, it's
Mm.
we have what, 10 minutes to see a patient, 15 if we're
Yeah.
lucky,
Yeah.
30 minutes if it's an annual exam. I get it. And I hear you guys. And I know that it's hard to tack on more, but we're not tacking on more. We're changing our language.
Mm-hmm.
We're starting
Mm-hmm.
at the basic level of access by saying, tell
Mm-hmm.
me what you do in your livelihood, and I'm going to make sure that this translates. And as I see you every 6 months to a year, because that's primary care,
Mm-hmm.
if anything changes off that baseline, we can reassess and we can change the forms to such to meet your
Mm-hmm.
needs and get you the accommodations you need.
Totally.
Right. So that's my pet peeve. My pet peeve and my
Yeah.
solution. I'm giving you the pet peeve.
Yes.
Change your language. Go by their livelihood. And like, please, for the love of God, do not say wheelchair bound. Do not say bound on everything.
Strike that off right out of
Take
your
it off.
language.
We're not handicapped. We're not special needs. We're not bound, right? We're disabled humans.
Mm-hmm.
We don't have anything special about us. It's just we need things that are going to make our lives just as easy as it is for you to be able to say, I'm standing up. I'm
Totally.
sitting down.
Totally. Well, I have one quick question about forms.
Yeah,
So it sounds like the form itself is problematic, right?
of
Um,
course.
and the place that the language starts is in primary care, which influences, right, everything out in like the world outside of primary care. So like what adjustments do you recommend primary care providers who are trying to provide assistive support or whatever accommodations that they need at their workplace? Like what is like a positive way to impact that from the provider perspective? Like a way of answering it or any thoughts there?
I think this is where we come back to that initial intake. What
Hmm.
does that initial intake form look like in your
Yeah.
practice? Whether it's private, whether it's in, with an insurance company, what does that intake form look like? Because then you're going to see what the patient is trying to address for themselves, right? So you're
Mm-hmm.
asking them their pronouns, you're asking them what they want to be called by, you're asking them, how do they address their own diagnoses? How do they address their disability? Are they paraplegic? Are they a wheelchair user? Are they a cane user, walker user, whatever? They're going to put that language on their intake form first. You're just asking, how do you address your own disability?
Mm-hmm.
You identify as a person with a disability. If they check off yes, then you're asking, the next part is, How do you identify with your disability? Wheelchair
Mm,
user, walker, cane user, whatever the case is, because that intake form is then going to pro give you the basic information in their own profile, whether you're on Epic, which I love Epic, or any other uh, programming that you use for that, for your patient information. It's going to be there. You're going to see how they address
mm,
themselves first. Now, with their baseline assessments, can they bend? Can they stand? Can they reach above their head? These are things we
mm,
squeeze. We have our patients squeeze our fingers to make sure that their hands
mm,
are the same,
mhm,
right? We
mhm,
check their feet for neuropathy. We
mm,
check their ears. The same thing goes for someone who has some type of physical issue. If you're sitting down and you're using a wheelchair, are you able to push yourself all the time? Do you do all your groceries on your own? Are you able to cook? What needs aren't
mm,
being met that you need to have met that we haven't discussed?
mm,
It's
mm.
having that conversation with the
Yeah,
patient.
yeah,
Because then when you're filling out those forms and it says, do you stand for 10 hours? You can cross out 10, stand, say sits, and you can say, yes, can sit fine for 12 hours, right?
totally,
Because you're the medical professional that understands that my body can sit for 12 hours and it doesn't need to
totally.
necessarily stand up.
Right, right. Which a non-medical person in a workplace setting may not be able to understand.
Stand. Right. But
That's
that's how the narrative changes on the paperwork.
yeah.
Because now I'm not just saying cannot stand.
Yes,
It
right.
cannot stand. That's it.
Yeah. Yep.
Ability is done.
Yeah.
Right? Cannot
Yeah,
see.
it's not
Cannot
like it's not
see.
affirming, it's just
Right.
negative.
It's just
Yeah.
saying it isn't. But this is where technology also impacts healthcare.
Yeah.
And we might not know what's out there, but we know
Mhm.
how the person lives day to day. And that's just in basic primary
Mm.
assessment. We
Yeah.
know how you live. We know how you're able to do something.
Yeah.
We assess every 6 months to a year.
Yeah.
We know if something's changing. So if your paperwork
Yeah.
needs to change, we change it.
Yeah. Yeah.
You can no
And it's
longer hold,
and there's no
hold the thought.
baseline. It doesn't really feel like there's a baseline assessment. Like it's very problem based where it's like, okay, you have visual impairments, you have hearing impairments, right? But it's not like that's not a routine part of our schooling or our practices really of like everyone should have that, right? And then it's just a normalized thing of like everyone has a physical, like all of these different assessments, and then what assistance do people need, because everyone's going to need something, right? And it's just a gradation piece versus like an exception or an afterthought, or like the way it's treated at least now,
Right. But
medical
and then in
education.
primary care, that's exactly how it works, right? Okay, I
Yeah,
see you come in, you're holding your arm, it can't stretch out. We should probably send you for an x-ray. X-ray comes back inconclusive. We send you to a specialist.
yeah,
But that's exactly how it works.
yeah,
It's we're not doing anything different. We're
yeah,
just expanding on where we're at for those
yeah,
that are coming in with different needs,
yeah.
because normally we don't include their needs into our notes
Yeah.
in
Yeah.
primary care.
Yep. 100%. Yeah. Absolutely. Well, thank you so much for this. Are there any other kind of like parting pearls of practice, words of wisdom, or any, if you want to share where people can find you and learn?
Yeah, so all my social media handles are at the seated nurse.
Perfect. And
You
we'll
can
have that
find
down
me
below in the
yeah,
description.
that's it. It's at the seated nurse. Find me. You can Google me. But my parting words to anyone that has a newly acquired diagnosis or disability, or if you feel overwhelmed listening to this, like, oh my goodness, just take
Mm,
a second and realize that we're not talking about anything other than human need and human needs being met. And as medical professionals, we get to firsthand see, care for, treat, and be the person that sees these people in their most vulnerable state. So we
yeah.
have the impact and the narrative to help them, so long as we keep it positive and not always just put a negative connotation over it.
Mm-hmm. Mm-hmm. Totally. Totally. Well, awesome. Thank you so much again. I so appreciate it.
Yes, Liz, thank you so much for having me.